Hello. Good morning, everyone. Wow, it is so cool to see so many of you from across the state. I actually recognize several of the names and obviously many of the facilities that are on here. So this is really neat. So, just by way of introduction, my name is Angie Morris. I am a registered nurse and board certified sexual assault nurse examiner. I currently work for Community Hospital in Anderson, but I also serve as a project education consultant for the Indiana SANE Training Project, which provides training and education to sexual assault nurses and multidisciplinary partners throughout the state of Indiana. I have experience as a sexual assault nurse examiner in both a level one trauma center and at a sexual assault treatment center, which operates a little bit differently. I've also worked with our statewide SANE coordinator over the past 6 or 7 years to build several different forensic nursing programs throughout the state. So um, I think I have a good pulse on forensic nursing as it relates to the state of Indiana. So if there's anything that you have questions about or just things that you're curious about, hopefully we'll answer most of those today. But if not, please feel free and let me know any questions that you have because we want to make sure that you have the information that you need to do your job effectively. I believe that I am sharing my screen. It looks that way. And so we are going to talk about medical forensic examinations. I will skip straight to the SART response and the role delineation. So within the sexual assault response team, we have many members. So, of course, we have the patient or the survivor is the center of this response. We have law enforcement officers. We have advocates. We have the medical system, as well as the judicial and legal system. And then we have child advocacy centers are often a part of that, and just other services that will support the patient or survivor. I say patient a lot, so if you hear me refer to patient, just understand I'm saying survivor in your language or client in your language, just so that we're all speaking the same way. But that does kind of show you the importance and just how different our roles really are. When you're coming at this from the perspective of law enforcement, your goal is to really investigate the crime. When you are a DCS official, you are working to ensure safety for that family, as well as helping law enforcement investigate that crime, and advocacy offering support in many different ways. And then when you look at the prosecutor's office, they're going to be the ones to make a decision about whether or not they are going to proceed by prosecution. Remember that when crimes are not prosecuted, often there's an issue, or perhaps they just can't prove that case beyond a reasonable doubt. Having some understanding of everyone's role and their goal and their responsibilities is definitely important as we move forward in this. And, our roles are all complementary. I always try to say it's like a used car salesman. Like, we don't want to all kind of pounce on this patient or survivor at the same time, because that could be very overwhelming and feel kind of icky from the survivor perspective. So essentially, we're going to wrap around them and give them space and information to make informed decisions about what happens next. So, what is a SANE? I'm sure you've heard this term. I will say our director at the Indiana SANE Training Project was in a meeting probably about a decade ago, and she likes to share this story about how someone in the room was commenting about how we need more SANE nurses. And she was like, "Yeah, my sister-in-law's a nurse. I know what you're saying." Haha. She didn't understand that SANE meant sexual assault nurse examiners. She always likes to share that she thinks that we're all a little not sane. And Indiana, we call ourselves insane, so that seems to work. But it's a registered nurse or advanced practice provider who has had additional education and training in the clinical components of the medical forensic examination and how to conduct that. So the value of the forensic nurse is really going to be that they are the individuals in the healthcare system that understand the medical and legal implications of caring for victims of crime. They're going to be well versed in that safety planning training as well as those biopsychosocial assessments and community resources. They are good assets to protect hospitals and medical facilities from lawsuits. And they will be better able to ensure evidence collection and evidence integrity as well as chain of custody. And the same can provide valuable testimony during the criminal justice process as a fact or expert witness. So, what happens during this elusive medical forensic examination? I want to pump that to you all. What have you heard as far as the medical forensic examination process, and the experience that maybe the people that you have worked with have had in the past? What have you heard about their experiences from the SANE exam? Or maybe you haven't heard anything. And if you could put it in the chat or even come off of mute, that'd be okay too. I just kind of want to get a feel for what have you heard about the SANE exam? Have you heard that it's traumatizing? Have you heard that it's embarrassing? Have you heard that it's painful? Yeah, Shannon, if you could come off of mute, that would be awesome. I don't.
Good morning.
Hey,
So I am new to my role and have not had a lot of time with clients. I've mostly been shadowing. But from what I understand, it is at times a very lengthy and invasive process. And something we need to do is allow them space to go at it at its own pace because it's their body and it's a
sure.
lot of things happening to their body.
Yeah, it's a lot at once, that's for sure. Anybody else want to share what they may have heard? I know Anna has shared that it's a very lengthy exam and can take up to 6 hours. Anybody else?
I we have a sexual assault treatment center here in Fort Wayne. I've gone to tour the facility and look around, and I always thought it was, I don't know if it's interesting or crazy, the age ranges that
Yeah,
that that go to receive treatment and such like that. Please correct me if I'm wrong because I'm still learning.
it's
um,
okay.
but I feel like some of the forensic examinations are more invasive and then others aren't, depending on, I think, timeline and stuff
Hmm.
like that, which I liked because it's like, well, if it's been so long, then we're not going to do this really
Yeah,
invasive cavity search or anything like that.
right.
So, which, I think is a really just kind of client-centered kind of approach.
Yeah. Well, thanks for sharing that. I love the facility in Fort Wayne. It's amazing. Their nurses are amazing. We're all really good friends. So, you have a great facility up there, and they operate um, very in a very unique model. So, we'll talk a little bit about that. Beryl.
Good morning, everyone. I work at Community Health Net Health Centers. Our main office is in Gary, Indiana. We are a federally qualified health center, and we have 9 sites throughout Northwest Indiana. We are a certified SANE program, and one of the things that we like to think we also have a partnership relationship long-standing with the local hospitals who are same sites. But there's an opportunity for referral and collaboration. We
Hmm.
like to think that our F2HC, our health center, is patient-centered. And
Yeah,
so, when people come in, we try and structure it, and we try and structure it so that we inform people of the length of time. Sometimes it's shorter than being in the hospital
sure.
emergency
Hmm.
room at our F2HC site. And we've been able to get feedback not only from don't necessarily bother the patient or the person who's coming in for the service, but we get a lot of feedback from our community partners about how we did, what we did, especially if it's referrals. We try and focus it as community centered, patient centered, and we try and do a lot of evaluation. Plus, our certified same nurse examiners, they are former labor and delivery nurses. So there's a complement of things
Yeah.
that we try and do. Thank
Awesome.
you.
Thank you. Thank you, Beryl. Anna, what about you? Last one here.
It's kind of Excuse me, like maybe a half question, half something that I have heard about the exams is that it is generally a very consensual process where
Mhm.
if at any point if the patient or client wants to like stop the exam or like skip a part that they are able to. I am not sure if that is actually entirely true for the entire
That
process.
is true. So, okay, we're going to talk about what goes on behind the curtain, as they say in The Wizard of Oz, right? So, during the medical forensic examination, we do get a history of the event that happened to them. That helps to guide not only the examination itself, but also the evidence collection process. As a part of that history, we also obtain the patient's past medical history, including their family and social history. We will do a comprehensive review of body systems, much like when you go to the ER or to the urgent care. They will ask you a ton of questions. We're really nosy about all the things. When's the last time you had anything to eat or drink? When's the last time you had a bowel movement? We tend to get up in your business. Of course, we do this in a trauma informed way, but we are assessing that whole body system, not just the genital area or areas that we may feel were impacted by the system. Because a lot of times, what we find in a medical forensic exam may not necessarily be because of the assault. So, we are trying to treat this patient holistically. So, yes, this is kind of the primary reason that brought them here. But we are going to work with them to ensure that all of their health needs are met, because we know that being a victim of sexual violence does result in a lot of medical sequelae. So if you are, a person who already has medical problems, we know that those are more likely to be exacerbated by this experience as well. Yes, they can complete an exam anonymously, and we'll talk a little bit about that as well. We will talk about the medical history. And we have Shannon saying that she will tell you the same is what made the ordeal less traumatizing. I love that that's true, because I think that's the biggest part of this. If we are doing it right, it should not be a traumatic experience. It should feel empowering, because we are returning the power back to the patient. So we will do a head to toe physical examination, and that will include an anal genital inspection if the patient consents to it. As far as a speculum examination goes, for those of you maybe who are not super familiar with the speculum exam, that is kind of that duckbill type device that we insert into the vagina to view the cervix. That is only used on adults and older adolescents, and only with their consent. This is not a required portion of the exam. So please help them to understand that we are definitely not going to go poking and prodding and doing things without their consent. They always have a choice about what happens next. We also do not use a speculum examination on children at all, under any circumstances. We will not do that. We also collect evidence, which may include photo documentation of findings. We will document all of the history as well as the findings. We will provide medical care and treatment of not only their injuries, but we also offer prophylaxis for STIs or pregnancy. We will generate referrals for non-acute medical conditions. So again, maybe they're coming in for sexual assault, but as a result of doing that cervical evaluation, we note that maybe they have some sort of cervical lesion and they need follow-up care for that. So we will help them find care for any of the incidental issues that we find. Safety planning, we will work with the advocate and or a social worker to ensure that the patient has a comprehensive safety plan. And for many sites, especially those operating within an emergency department, your patients will also have a social work consult. So that's kind of all of the things that happen. It doesn't give you an exact understanding of what happens, because as you all have alluded to, every exam is a little bit different, and the details are what's going to provide us with the most information and tell us what needs to happen. So we'll talk a little bit more about that here in just a few minutes. Patient options. So again, we did talk about this briefly, but as someone said in the chat, if a patient declines that medical forensic examination, or maybe the event happened outside of time frame for evidence collection, we still should be seeing them as sexual assault nurse examiners. And if a patient wants to see us. I know that that can be kind of challenging because maybe they're like, well, what's the point? The point is, one, we want to make sure that they are safe and healthy. And this is not all about evidence collection. And if your nurses are saying that, well, this is only about evidence collection, or we do this for evidence collection, unfortunately, they're missing the point. This is not about evidence collection. This is about comprehensive health and wellness. Evidence collection is kind of the yeah, but at the end. Oh, yeah, we also collect evidence. That's a part of our job. It's a duty of our job, but it is not the sole purpose of this same exam. So we will discuss with that patient their general health. We will talk about STI prophylaxis. We will address mental health concerns and their chief complaint. Maybe they're coming to us because they're still having pain or bleeding or bruising. We will also talk to the patient, as well as, for those who don't want the medical forensic exam, would they like to report to law enforcement? They still have the ability to do that, even if they have not had a medical forensic exam. And the patients can speak to or visit with a victim advocate, whether or not they have a medical forensic exam, and just providing resources. So again, even if a patient opts out of this exam, you may be the only person that they disclose to. And so it's really important that they have an understanding that they're safe, they're supported, and that they know what some of their options are as far as what can happen next and how they access those options. Some of the examination options, again, patients can consent to as much or as little as they wish. They are in full control when they're in our facility. And the patient has an option of having the advocate or a support person present for that exam. Patients over 18 have the option of whether or not to report a crime to law enforcement. So if they choose to make a report, the forensic nurse can also assist with this process. For patients that are under the age of 18, the state requires that we are mandatory reporters. So if we are made aware of a crime or a reason to suspect that a child has been a victim of crime, we are mandatory to report those to the state. So we will make a referral to Department of Child Services and report to law enforcement in the jurisdiction where the crime occurred. Patients may decide whether or not to have evidence collected. So maybe they want to come in and see us and they just want the STI and pregnancy prophylaxis, but they don't want to have the rape kit done. That is totally understandable. Again, we talk to them about their options. We talk to them about their goals and their risk, benefits, and alternatives for every choice that they make so that they can make an informed choice. So again, just because a patient is outside of time frame for that acute exam and evidence collection, they can still be evaluated and have those findings and that history documented, as it can be an important aspect of the investigation and their own healing. Reporting requirements for healthcare providers. So you are, as well as myself, are mandatory reporters. So again, what that means is if we're made aware of or suspect a crime against a child, including abuse, neglect, or molest or sexual abuse, we are mandatory. So in this sense, or teenagers and pediatrics cannot be Jane Does or anonymous reporters. We also have to make those reports, even if we're not able to substantiate it. So, sometimes we say if your gut is telling you like you need to follow that gut, we will make a report. And many times there are times where Department of Child Services will screen out what we've reported because they just don't feel like they can substantiate it, or they don't, it doesn't meet the criteria for screening in, but that does not absolve the healthcare provider of making that report. So investigations and attempts to substantiate those claims of child sexual abuse fall outside of our scope of practice. So we just do not do that. And we also cannot delay a report. So what that means is if I see a kiddo today, I can't say, okay, well, I'll just report that to DCS and law enforcement tomorrow. It needs to happen within that visit to ensure that they are safe for discharge and that we can discharge them and that there's a safety plan in place for them. Some of the limitations of the medical forensic exam itself: it cannot in and of itself confirm if a patient has been sexually assaulted. So I know that there are a lot of myths about the anogenital anatomy, especially that of a female. The hymen myth, I will tell you, is false, and I'm sure we've all heard it, but the hymen is not this like invisible force field that keeps everything outside of the vagina. It doesn't work that way. If it did, it would be so much easier, but that is not true. The hymen is actually a thin membrane around the vaginal opening. So if it is basically like covered or something like that, if the hymen itself has no opening, that is a medical condition that would have to be treated because that can cause infection and things like that. So that hymen is an open tissue. It's kind of like a scrunchie. It does expand and contract based upon things like the presence of moisture, lubrication. It also expands and contracts just by muscle contractility. It will move with positioning and things like that. So just because we've had a lot of confusion about the hymen, and I think that's the one thing that we spend the most time on when we are providing jury education and things like that, is that everyone has this understanding that if someone was sexually assaulted, there has to be anogenital injuries, and that is just not true. We cannot confirm the presence of semen or DNA at the time of the exam, so we will take the samples, we will submit those into the sexual assault evidence collection kit, and that kit will get tested by, in most jurisdictions, it'll be the Indiana State Police Crime Lab, and if they're in Marion County, it will be the Marion County Crime Lab. It does take a while to get results of DNA testing. That is not something that happens overnight. That process is driven by law enforcement. So these kits are not tested at the hospital. We really have no say in what items are tested. The state police has a protocol on what they test. So not even all items in the kit may be tested. So the benefits of the medical forensic examination, again, this is not just about having that evidence collection. We want to reassure the patient that their body is okay, they are normal. This is especially important for our kids who think that people are going to know that something happened to them. We like to assure them that no one's going to know unless it's something that they wish to share. No one's going to be able to tell just by looking at them that something happened to them. We want to make sure that we're providing trauma-informed care, that we get access to resources, including advocacy services, which are going to help set the foundation for healing. We also want to emphasize that the patient is believed and supported, and that what happened to them was not their fault. I know sometimes, especially with teenagers, maybe they've done some things that got themselves into a high risk situation. And so there's a lot of self blame there. Sometimes, hey, maybe you weren't following the rules, but that doesn't mean that this was your fault. So we try to really help them understand that, so that they're removing some of that shame and that self-blame. We will do that thorough examination and documentation of that history and the findings, and make appropriate referrals and address any of their concerns and fears, both medical and emotional. So it's a great time for them to ask questions. I think one of the biggest reasons why we do this is for that time to ask questions and to make sure they have an understanding of what happens. I once had a 12-year-old who was sexually assaulted, and the question that she had for me was just absolutely heartbreaking. It was just basically, she was like, well, I know that this means that I'll never be able to have a baby. And I was like, oh, back up a minute. So we had the ability to kind of explain, no, that has nothing to do with this. And if you think about children who are sexually abused, often will adopt some kind of high risk sexual behavior. So if she hadn't had a chance to have this discussion in an open, non-judgmental environment, she might have thought, well, I can't get pregnant. She might have then participated in unprotected sex. We might have ended up with a pregnant 14-year-old. So just making sure that they can have time and space to really ask the questions that maybe they're too afraid to ask their parents, or too afraid to ask the doctor that they see every single year. So that is also one of the reasons that we kind of stick around and make sure that they have all their questions answered before they leave. Again, like I said before, it is normal to be normal. And what that means is that most of your examinations, most of the patients that we see after a sexual assault exam will not have any visible anogenital injuries at the time of the exam. And that does not mean that nothing happened. So why would there be no injuries or evidence? There are a various number of reasons for that. When we think about children, especially, we think that they have a delay in the disclosure, or even a delay in seeking medical care. We know kids do not always disclose this information straight away. So often there will be a delay. Children disclose more of as a process than just a singular event. So for that reason, we might not see that kiddo or that patient for many days, weeks, even months after this happened. And so if that's the case, if there were injuries, we're not going to see them. If there was evidence, we're not going to get it. And so that is definitely a reason why those exams could be normal, as well as the presence of DNA. So when we think about post-assault activities, did they wipe? Did they wash? Did they shower? Did they change tampon? Those kinds of activities can interrupt evidence collection. We also want to think about that human physiological processes. So, when we think about the vaginal opening and the vagina and those structures and the human physiological process of sexual development and sexual activity, it is an involuntary process. So that means even if that patient is not consenting to that exam, the body is basically preparing itself for a sexual encounter. So that means that, you're going to have expansion of tissues, you're going to have increased lubrication. All of those things make it less likely for an injury to occur. And then when an injury does occur, healing is often very rapid. So if we don't see them right away, that healing can happen very quickly. And so we might see them a couple days later, and by that point, everything is already healed. Also, some forms of sexual abuse do not leave physical findings, and that is very important when we think about those cases that involve fondling and things like that. We're just not likely to see physical findings based upon the type of activity that was involved in that assault or event. And, perpetrators, they don't want to lose access to their victims. So this is especially true when you have a chronic child sexual abuse situation. They know if they hurt this kid that they're probably going to get found out. So they're very careful not to cause any pain or injury, because that really puts them at risk for that kid to say, hey, this hurts and I'm going to tell because it hurts, or I'm going to talk about it because it hurts. So those are some of the reasons why it's normal to be normal. So timeframes for evidence collection. What I mean by timeframes for evidence collection, that means that in the state of Indiana, our protocols and jurisdictions vary, but generally we can collect evidence from 96 to up to 120 hours for physical evidence collection. That again does not mean that because they are at 124 hours that they are not seen by a SANE. We are not just about evidence collection. So really help to advocate for your patients or your clients. If they are wanting a SANE exam, if they are wanting that medical forensic exam and they are outside the time frame for physical evidence collection, kindly and respectfully remind those nurses that this is not about evidence collection. This is about holistic care, and they have the right to have access to that care even outside of those timeframes. So this is not just about that physical evidence. In many cases, perhaps there are patients who don't know what happened to them or they don't know when it happened. We can still collect respective samples within those timeframes, and those samples can be evaluated by the crime lab. But the most important part of this, I want you to know, is that the patient still can be seen by a SANE or medical provider outside of these timeframes. It's not just about evidence collection. Timing of medical forensic examinations for your pediatric and prepubescent children. Emergency exams, those are kiddos that we're going to want to see within those 72 to 120 hour timeframes. We want to see them if there's a need for emergency contraception or post-exposure prophylaxis for sexually transmitted infections, including HIV. There will be times, especially at our center, we do see, and I know Fort Wayne does quite a bit of these as well, we do non-acute medical forensic exams. So that's especially important for kids with those delayed disclosures. So they may talk about something that happened 1 or 2 weeks ago or even months ago. You will still do an examination on them. With chronic abuse, you just never know what you're going to find. You don't know if you don't look. So we want to make sure that we do that comprehensive evaluation and that we are evaluating them follow up anytime we have anogenital findings that we're just really not sure what we're looking at. We have to think in terms of differentials. What else could this be? Even if we know that this patient was sexually abused or sexually assaulted, and we have anogenital findings, we have to think, is there another potential cause for these findings? We don't want to just go straight away to the fact that they could be attributed to the sexual assault. They absolutely could, but let's ensure that we have ruled out other medical issues that may have resulted in similar findings or something that could easily mimic a finding caused by sexual abuse. When it comes to pediatrics, what type of exam, how soon do they need to be seen? I've just included this algorithm for you. Hopefully it's helpful, but again, some facilities do 72 hours, some do 96. Our facility will see you up to 120 hours for that evidence collection. There are times where your medical provider will see them for evidence collection beyond 120 hours, specifically if a patient was abducted or has been held captive, those kinds of things. We would certainly collect evidence on them. Even if they're outside of that time frame, because they've been in a situation that they couldn't get out of. There may be findings that we just don't know about. So again, that exam is just so very important and so much more than evidence. When we talk about children and adolescents, just to reiterate, please, if you have a kiddo, unless you are a child advocacy center or forensic interviewer, please do not ask the child details of the event. This is especially important if that child has not yet had a forensic interview. Likewise, we do not want to discuss details of the event with parents in the presence of the child, especially before a forensic interview. So if you are talking to parents and they start kind of rattling off everything they know about the event, just kind of try to put a pause on that and get that kiddo and or any siblings out of the room, because we do not want the appearance that there's been any kind of tainting of this disclosure process or any coaching through this disclosure process. Timing of exams is different than for adults. We already talked about that. We will do non-acute exams for kids. It's very important that we do. So even if that child falls outside of that time frame for evidence collection, they should still be set up for non-acute examination with that forensic nurse. We also do not provide services to populations, or we don't recommend that you provide any kind of services for populations that you have not been specifically trained to serve. So what that means when it comes to children, make sure that if you're providing advocacy or support services to children, that you are following the standards from the National Children's Alliance for Child Advocacy Services as defined by the NCA. Be aware of the redundancy of services and that it can cause confusion and compromise the investigation. And when there are too many players at the table, it does get confusing. Parents and caregivers and even the kids often don't know who's leading this process. Like DCS is saying, I need to come to this appointment on Monday at 2 p.m. The Child Advocacy Center is saying I need to come to their appointment on Monday at 1:30. Like who do I listen to? You might have a law enforcement officer that says they need to see you on Monday at 1:45. Like, who do they listen to? So if we are not appropriately coordinating these services and working as a team, it can be very overwhelming for the patient, for the family, for the caregivers at the center of this. So again, remember, we're coming to wrap ourselves around and not really pull them in 5 different directions, because that is just dysfunctional and we don't want to be a part of causing more trauma. For information involving advocates in pediatric sexual abuse cases, we do have guidelines for medical forensic examinations of pediatric patients. You can find information on the implementation of advocates through that process in those guidelines. Before their examination, if you have a patient who does want to be seen and maybe you talk to them before they've had that medical forensic exam, just make sure that the patient is somewhere safe. If at all that they can avoid showering, that is our preference. Avoid cleaning up, washing sheets, changing clothes if possible. I know sometimes that is just not possible, and we understand. And remember, we're going to document all of the things that they've done since this event that might disrupt evidence collection potential. So, if they absolutely cannot wait to take a shower, that is fine. This is about their choices and their decisions. We just want to make sure that they understand the risks, the benefits, and the alternatives of what they're about to do. We also recommend that you transfer patients or refer them to the nearest facility with a scene on duty. This is super important in that we do not want patients from Evansville driving to Indianapolis to have a medical forensic exam when there are several places in between Evansville and Indianapolis that they can get an exam. So that doesn't make sense. It is not patient focused. It is not family focused. And so we just want to avoid putting these families and these caregivers in very difficult situations that might result in them just terminating care altogether. The payer for the medical forensic exam portion, especially if it's an acute, meaning within those 120 hours, or if it is a child, regardless of how acute the case is the Indiana Criminal Justice Institute. They operate through a Victims of Crime Act fund, so that is a federal fund, and those examinations are paid for out of those federal dollars. That pays for the exams with evidence collection, whether or not that patient is cooperating or working or reporting to law enforcement. During that exam, again, those exams are conducted by either a physician or a nurse with specialized experience. This is not a law enforcement driven exam. Law enforcement officers are not in the room during the medical forensic examination itself. These visits can take several hours to complete. So yes, that is accurate. So you want to make sure, if you have a patient who wants to be seen for medical forensic exam and it's about 12:30 and they have to pick their kid up from school at 2, it's probably best that we wait until they get their kiddo taken care of before we get that process started, because otherwise they're going to interrupt it, or they're going to get anxious because they have to leave and they're going to terminate care, and we don't want that for them. The patient is in control of the exam. They can consent to as much or as little as they wish. This exam should not be painful. If it is, we are doing it wrong. So if your patient or your client reports that there's been a painful encounter, please make us aware of that so that we can do better to train the nurses appropriately and provide them the support they need to ensure that they're not causing pain. There are going to be times where it's just uncomfortable and it's hard. And, we get that. Being in an uncomfortable and a hard situation is not in and of itself traumatic. So we want to make sure that we empower patients that, hey, this might be uncomfortable, but you know what? We can do hard things. We do hard things all the time. This is a hard thing. We acknowledge that. And acknowledging that returns the power back to the survivor. Samples and swabs may be collected and maintained for the evidentiary testing. Medical testing and diagnostics may also be completed depending on what the patient reports. If they report that they were strangled. Strangulation is an acute medical situation that can have a lot of medical consequences. In that case, we would want to see those patients because they do need a CT of it's called a CTA, it's of their neck and the structures in their neck to ensure that they do not have some sort of blood clot or carotid dissection or something like that. We also may collect their clothing or undergarments as evidence. Again, that is with their consent. The victim will be asked about the incident to kind of help guide that exam. They will be asked about recent consensual activity, and that is for evidence testing purposes, also to assess for pre-existing injury. And they may be asked very personal questions about their medical history, the health history, and or the assault history. So just so that you know that these things all do happen and that we can better prepare them for when they come to see us. Some tips for handling disclosures. So do adjust your body language, make sure that you're face to face, that you're giving them eye contact. If it's a little one, I always try to go lower than them so that they feel in a place of empowerment, and making sure that you reiterate that you do believe them, that you appreciate that they have felt safe enough to share this information with them. To the best of your ability, let them know what will happen next, and make all of your documentation using the patient's own words whenever possible. And things that we want to avoid using shocked or disbelieving words or body language. Oh my gosh, your dad would never do that to you. That that is very minimizing. So we don't want to be a part of minimizing their experience. And so make sure that we avoid things like that. Don't try to talk someone out of the disclosure. Are you sure? I know your uncle loves you very much. He would never do anything to hurt you. Are you sure that this is what's happened? I think we see this a lot of times in family situations. Also, don't discuss allegations with others that are not essential to the investigative process. This can betray the trust that the survivor has in you. We also spoke already about not discussing allegations with parents or caregivers in the presence of the child and or their siblings. Siblings are important because where we have one child sexual victim, we are likely to have more than one. So we want to make sure that all of the children are taken care of in those situations. Do not try to investigate this matter on your own. That is beyond your scope unless you work for law enforcement or Department of Child Services. Please don't do that. And also try to avoid asking leading questions or attempting to conduct a forensic interviewer unless you are the forensic interviewer. And also, this is important for healthcare providers as well. We try to avoid diagnostic words or trying to confirm abuse or causes of anogenital findings on those exams at the time, because again, we just want to be very careful about overcalling things as well as undercalling them. So we want to make sure that we have a comprehensive picture of what happened, what has happened since, what are the other medical potentials for what we're seeing to make sure that we're absolutely certain. Because again, we also don't want to find ourselves in a situation where we are collecting information and evidence that puts, maybe someone who is innocent of a crime behind bars. We don't want to be a part of that either. So the 5 Ps, this is one thing that I do think is super helpful, especially as you are working with clients and you're kind of like, I don't know, do they need an exam? Should we make a referral to a SANE? Should we not? Think back to the 5 Ps. Are they having pain or bleeding after the contact? Is there a potential for sexually transmitted infection or a positive sexually transmitted infection result? Was there a perpetrator exposure? So again, in those family environments, if we know that we have one victim with an outcry, we know that we have one child in that family that has an outcry, are there other children in that home or in that family who potentially could have been exposed to this perpetrator? Those are kids that we would want to see. Child pornography. So they call them child sex abuse images. We no longer use the word child pornography, but if it helps you remember as one of the P's, if they were found in images of child pornography, or if they were made to view pornography, those kinds of things, we would definitely want to see those children as well. If there's a patient or parent concerns, they would be indicated for a medical forensic exam or at least some sort of a triage to kind of see if that exam is indicated. Who should be seen by a healthcare provider? Honestly, anyone with pain, bleeding, or injury post assault, anyone who's experienced strangulation or suffocation. Again, this is a very dangerous activity and there's a high risk of medical consequences, and they will have no idea whether or not they are in the clear without medical imaging. So strangulation is just very serious, and we want to treat it as such. Anyone that is experiencing a mental health crisis after the assault, and anyone who just wants to know that they're okay and wishes to be treated for sexually transmitted infections or get access to pregnancy prophylaxis. How to find a sexual assault nurse examiner. So if you go to the website usi.edu/Indiana SANE, there is a document on that website called Indiana Medical Forensic Examination Providers. This is a list of providers. It is updated quarterly and it is sorted by county. The Indiana State Department of Health also has a GIS map to help you find providers in your area. So just learn about the facilities, the 1 or 2 facilities that are maybe closest to you so that you can provide your patients options. Sometimes, maybe they're specific to getting their health care. They're very centered around one healthcare organization. Maybe they don't want to go to another healthcare organization. So again, just making sure that they have options and letting them know, hey, you do not have to drive 4 hours for a SANE exam unless you want to. And if that's what you want to do, we're going to help facilitate this process to make sure when you get there 4 hours from now that you don't get there and find out, well, that SANE nurse, she's usually here, but she's out on maternity leave right now. We don't want that to happen either. So making sure that you know how to find a SANE, that you are able to call ahead and secure, or at least just verify that someone is there to receive that patient is going to be super important. Victim advocates, you all kind of know your role, but you have such a crazy responsibility, and it's just, we cannot do this without you. We appreciate that you offer so many services to us as healthcare providers, because there's so many things that you all just have access to that we have no information about. So, in addition to that emotional support and providing that crisis intervention, knowing about those resources and referrals, you're also well versed on information about the criminal justice system. You can accompany victims to court appointments and hearings. Those are things that we as healthcare providers do not do. We cannot do. That you are informed about access to victims of crime funding assistance that those patients or victims may be eligible for. That you can provide assistance with landlords and creditors and employers and safety planning and protection orders, and maybe they need to break a lease to get away from a defendant. And those are all things that we really do rely on you and your support for support groups, counseling resources, all of those things. The one thing is, if you're ever in a situation where you are doing a medical forensic exam or you're in the room when it's happening, just make sure that no one offers you to assist with the evidence collection process. That would not be appropriate. I don't think that that's ever happened, but sometimes in this field, there's no such thing as stating the obvious. We just want to make sure, again, that we are all staying within our role and delineation. For those of you who have not seen it, this is just a sample of the State of Indiana Sexual Assault Evidence Collection Kit. This looks like when we talk about swabs and samples. This is what is inside the kit. These are basically just Q-tips. Those are how we collect the samples. We will get them lightly moist and swab over the area of potential concern, and then we package all of those samples and send them in that sexual assault evidence collection kit. That gets surrendered to law enforcement, and law enforcement will make a determination as to the testing and submitting that kit to the Indiana State Police Crime Lab. Prior to making a referral for a sexual assault examination, just contact the facility. I talked about that. Just please make sure that someone's available and give a brief patient report. What do you know about what has happened so far? What do you know about the disclosure? Just some basic information is fine. If you don't know anything and you don't want to have the patient retell their story, then please don't ask them. We can take care of getting that history. But do try to speak directly to the forensic nurse that is on duty or on call whenever that is an option. If they have to be paged to call you back, that is fine. We want to know basic information of what went where and when, what body parts were involved. If you know, that's great. If you don't, it's okay. Again, you don't need to go assessing these things. But we do want to know, is the patient safe? Do we have any reason for the to suspect that the perpetrator is going to show up at the medical facility? Because if so, we want to make sure that we are working to ensure the safety of not only the patient, but also the healthcare providers and other patients that are in those facilities. We want to make sure that they have an understanding of the exam, just a brief overview, but nothing that's going to be overwhelming. And I think that's really hard to kind of balance. Like, how do I give them enough information without making it sound just absolutely terrifying? I always try to remind patients and parents this is not going to be painful, evasive, etc. And how this is presented is going to impact whether or not they receive care. So we really do rely on you all to help us present this in a way that they will receive it and that they will understand that they're in the driver's seat about what happens. And, this isn't meant to cause pain or anxiety. This is meant to be empowering, and we will empower them to the best of our ability. And if that means that the patient doesn't want a blood draw, then we're not going to do it. If it means a patient doesn't want to have a speculum exam, then we're not going to do it. So we want to make sure that they have understandings of you're in the driver's seat, and we want to really reiterate that with them so that they know that they can come in here and say no to anything they want, and we will respect those decisions. When that patient declines medical forensic exam, again, just, or even if that exam occurred or the incident occurred outside of that time frame, discuss with them, hey, you still could be seen by medical, and these are some of the reasons why, maybe to discuss their general health, maybe to address STI prophylaxis, mental health concerns, any of their chief complaints. Also ask them, would they like to report to law enforcement? If yes, please call dispatch so they can do that. Offer to contact an advocate on their behalf, offer a social work consult. You can also provide resources. We talked about that. You might be the only person they felt safe enough to tell this to. So when it comes to adults, we will also offer that STI prophylaxis following the CDC guidelines. And we will complete that thorough documentation. Thanks for your question, Anna. We can talk about that here in just a moment. That's a really good option. So let's get into that here in just a minute. I think we are almost done here, and then we can talk through some of the scenarios. Just want to troubleshoot through some of the concerns that you may have about the exams. Some of the questions that we as healthcare providers ask, we try to be very trauma informed, but please recognize that some of our nurses are new. Some of our nurses just haven't had the experience or the exposure or the coaching to be, really, really great at this yet. So, they may ask questions in a way that feels like victim blaming. They may ask about alcohol or drug use. They may ask about, how much were you drinking? In what quantity? How many shots? And it may sound very accusatory, and it is not intended to be, especially when it comes to drug use and alcohol use. We know that drug facilitated sexual assaults are profound. A lot of times perpetrators especially, will use a victim in a situation where they've let their guard down, and that makes them more vulnerable. So just having an understanding of their level of intoxication is very helpful to us, not only from a medical perspective, but also from that legal perspective of, were they even able to consent to this type of activity? So we do ask a lot of questions when they have been impaired about their level of impairment. Has that resolved? And those kinds of things. It's very important. And if you're in the room, I just want you to know why we do it so that it doesn't come across as victim blaming. And when you understand the why, it's a little bit easier. Sometimes we do have to transfer patients for a different level of care. The medical forensic exam is important, but if we get a patient who has more acute issues than this, we have to address airway, breathing, circulation, and any injuries or findings that could cause death or disability. That has to be primary to that evidence collection piece. So there may be times like, hey, we have a SANE on duty, but they didn't do a sexual assault exam at the first hospital and they transferred the patient out for a CAT scan. Well, that's because that CAT scan was more important at that time to that patient's care and treatment and their livelihood than this evidence collection. I know sometimes there's questions about why advocates aren't notified immediately upon patient arrival. Just making sure that everyone understands that there are federal guidelines and through EMTALA and CMS regulations that require that we maintain patient autonomy, confidentiality, informed consent, and HIPAA. So we have to ensure that we get their okay to make these notifications, or that we have their consent prior to introducing an advocate into this process to ensure that we don't violate their rights in any way. And who to contact if you have concerns. If you have a facility that you feel, wasn't doing something that they should have been doing, who do you escalate those issues to? We do have a statewide SANE coordinator who works at the Indiana Department of Health. I will provide her information at the end of this presentation, just so that you will have someone to contact if you ever have concerns about forensic nursing practice or things that are happening in your community. None of this is meant to be punitive, but we also want to make sure that we find resolution and that we are doing the very best that we can on our end to ensure that the patients are taken care of. So we can't fix problems that we don't know exist. So please, if you have concerns, please reach out and let us know, because we do want to make sure that we are a supportive and reliable member of this team. And we just can't fix what we don't know about. Some resources, just if you're ever interested, the End Violence Against Women International, or EVAWI, does have a medical forensic exam virtual practicum. We do recommend it for all of our nurses. However, there's a lot of just really good information in there for advocates if you ever want to do it. It is online, it is completely free, but it will walk you through several different forensic examinations so you can see what those look like. We also have adult adolescent guidelines and pediatric guidelines at both the national level and at the state level. Guidelines are just that. They are guidelines. There are going to be facilities that practice in ways that maybe are not reflected in those guidelines. There may be reasons for that. There is also a national SART toolkit. Of course, I'm sure many of you already know about the 988 Suicide and Crisis Lifeline. If you don't know yet about township trustees, make friends with your township trustee. They're going to be an incredible resource to you, as well as Indiana 211. My contact information is included on here, and so is that of the Indiana statewide SANE coordinator. She would probably be your best bet if you had questions or ongoing concerns in your own community, and kind of need support and resolution. Her name is Ashley Smiley. She's at the State Department of Health. Her email and phone number are on here for your reference. And I'm going to go back to some of the questions that came up. Let's see here. I know that someone had a question about, can the medical history be used against the client in a criminal trial? They sat in on a trial where that happened and her medical information was used to embarrass her. So yes, unfortunately, that can happen. Most of the time, the medical aspects of their care, there are laws in place and processes to protect their medical information, specifically patients who have mental health conditions, those kinds of things that can be protected. I don't know the specifics of that. Unfortunately, any history, any information can be used against anyone in a trial. When you think that, the defense attorney's sole responsibility is to provide defense to their client, how are they going to do that? They're going to do that by trying to discredit a lot of the actions or the activities of the investigators, of the nurses, of, whomever was involved in that process. And part of that, unfortunately, sometimes can be exploiting medical issues. So we really just want to make sure that the jury has access to the truth, because that is what they need to make an informed decision as to a defendant's guilt or innocence. So sometimes it gets a little difficult. But again, patients have the right to omit information when they are talking to us. Oftentimes they do, right? So we are going to treat based upon what information they provide us, knowing that sometimes people just aren't going to be forthcoming because they are concerned about those things. Unfortunately, those are things that we just cannot change. And us as medical providers, we really are required as a fact witness to remain completely objective. And that's a little bit different than your role as an advocate. We have to appear as though we are approaching this from a complete place of objectivity. So that means that we document what we are told, whether it is whether something that may make the patient look bad or not. And we have to be that objective party. So that's, again, a little bit different than some of the roles of other team members. That's a really great question. I probably didn't answer it, but I'm trying to at least offer an explanation for where we are. Anna has a good question. As an advocate, do you think telling a client that the exam may be invasive can help them feel prepared? Or is it best to avoid that language in general? I say it is best to avoid that language in general. The reason for that is, yes, it can be invasive. Absolutely. But that's only if they're okay with that. So if we say it can be invasive, they're going to think, God, I'm not signing up for this. I've already been through enough. I already have enough people in my business. I've got these law enforcement officers asking me questions. I've got advocates that are supporting me. I don't know where to turn. And now you want me to go and do this incredibly invasive examination. I know that there are people who have watched TV. They watch Law and Order. Everybody does, right? Dum dum. But so we're all watching Law and Order. We all think we know what happens during a medical forensic examination. And we all think that we're in here taking pictures of patients fully nude. Listen, we do not do that. If we're doing that, that's something that you need to report to our statewide SANE coordinator because that is not trauma-informed care and that is not best practice. We should not be doing things like that are going to just really harm that patient's psyche. And that would be one of those things we just don't do. So when we use words like invasive, I think they, in their minds, go to, oh, I saw this on Law and Order and I'm not here for it. Oh, well, having a camera in between your legs can be really invasive. Yes, it can. But, if they have an understanding of getting quality pictures is going to help us consult with other members of our team so that we can avoid having you re-examined by another provider, they might be more open to it. So I think it's just best if we avoid that language in and of itself, explain to them what could happen, and reiterate that, you're in charge. You're in the driver's seat when you come. So yes, you may be given a lot of options, but you let them know what you are okay or not okay with. I think that's a really great question. Do we have any other questions before we move on to our next activity? So we're going to do a quick little Kahoot here. And I think maybe some more questions or concerns will pop up after this. So what we want you to do is go ahead and log into this Kahoot. You can join it with the game pen or you can scan the QR code. And while you're getting set up, go ahead and just get yourself set up. And if you have any other questions, type them in. I see someone has asked for my email, so I'm going to put that in here real quick. There's 45 people on this call, so hopefully we'll have at least 40 players. We'll see. I know these virtual meetings can be really difficult, so I'm trying to jazz it up as much as possible. Give you just a few more minutes to get logged in here. Okay. All right. We're going to go ahead and get started just for the sake of time, but you can keep joining anytime. Okay. All right. So your first question is going to be a true or false question. And it says a patient will need to complete all aspects of a medical forensic examination in order for a case to be prosecuted. Is that true or is that false? All right, correct. The answer is false. So again, that patient can consent to as much or as little as they wish, and these examinations can be tailored to that patient's needs and treatment goals. And while each step of this exam can be beneficial to the investigative process, the patient is always in control of the exam. So decisions about whether or not to prosecute a crime, those lie solely with the prosecutor's office, and a variety of things can impact those decisions, including the survivor's cooperation, the investigation, and the presence or absence of evidence. And that can include like physical evidence, witness statements, DNA, electronic evidence, all of that stuff. So the prosecutor has that burden to prove certain elements of the crime, and they have to do that beyond a reasonable doubt. So decisions about prosecution are going to be made by the prosecutor's office. So good job. Everybody got that one. So this just comes down to who was fastest. All right. Our next question is another true and false question. A patient must have an advocate consultation during their visit of treatment as required by Indiana law. Okay, so we have some splits on this one. The answer is actually false. So this one is a little bit of a trick question. So while a victim has the right to speak to a victim advocate or victim service provider during their course of treatment, it is not required that they do so. So according to Indiana Code, healthcare providers must notify a victim advocate must notify victims of their right to speak to a victim advocate. But ultimately, that patient may make a decision to decline or delay this interaction. Healthcare provider may not involve a victim advocate without the patient's knowledge or consent, as this is a violation of patient privacy, confidentiality, and right to autonomy. Medical care should never be delayed to await the arrival of a victim advocate, as this can result in medical consequences for the patient and liability issues for the healthcare facility. Let's see our leaderboard. Looks like Maddie's still in the lead. All right, next question is true or false. Mary states that she was sexually assaulted 2 weeks ago. She can still be seen by a SANE for examination. All right, let's see what's here. Okay, so the answer to this one is true. While there may not be any viable opportunity to collect physical evidence, such as a rape kit, Mary can still be evaluated by a SANE. She may still benefit from having the history of events documented, receiving medical evaluation and treatment for STIs, injuries, and post-assault symptoms, as well as safety planning and follow-up care to support her recovery. Good job. See where our leaderboard is. Shannon, you overtook her. All right. Let's see. Our next question is, Which of the following clients will need priority medical care? So, A, we have Lucy, who is 25, who was physically assaulted last night. She has a large amount of bruising, redness, and pain to her left eye. B, Melissa, 43. She was strangled by her husband 2 weeks ago. She has a raspy voice, sore throat, and tenderness to the right side of her neck. Abigail is age 19. She was assaulted 2 days ago, but refuses to press charges or have a medical forensic exam because, quote, it's not going to matter anyway. Or D, Donna, who is 67, who was anally penetrated by a man she met on Tinder last night, states she did not consent to anal intercourse and reports a moderate amount of anal pain. So the question is, which of these clients needs priority medical care? I love we're all over the board on this one. This is good. So this is going to help us learn a little bit more about that priority. So essentially, while all of these patients would benefit from medical care, Melissa is going to be the one that we in the medical world are most concerned about because of that history of strangulation. She still has ongoing symptoms that require evaluation. So even though her strangulation occurred 2 weeks ago, she still meets criteria for radiographic evaluation because she's still symptomatic. So that is concerning at this point. Good job, guys. Tough round. It says 10 participants lost their answer streak. I know. Sorry. All right. If you guys are like me and you're super competitive, like we want to win, right? So, all right. Question number 5. Which of the following patients has indications that are appropriate for a sane forensic examination? Select all that apply. So, A, we have Reed, who is a 7-year-old who reports that his 10-year-old brother is molesting him. Its mother refuses to have the child examined, and DCS supports this decision. Reed's mother does not believe the child, and DCS case manager says, quote, nothing happened. Georgia, who's 44, she was raped and physically assaulted by her husband 6 days ago after he learned that Georgia had an affair with a coworker. She has several visible injuries, including a black eye, pain, and tenderness to her left shoulder. She doesn't want to report to law enforcement, stating, quote, I brought this on myself by messing around with someone else. We have C, Ellie. Ellie is 2 years old. She has blood in her diaper, but urgent care said she's fine. But mother still has concerns and doesn't understand why no one is helping her child. And we have Jeremy D, who is 21. He woke up at a college fraternity party 2 nights ago with his pants around his ankles. He was intoxicated, but remembers someone, he's not sure who, sucking his penis without his consent. He also reports that his bottom is very painful and he refuses to report to campus police. So which of these patients has indications that are appropriate for sane exam or forensic nurse exam? So the answer is all of these patients have the right and indications for evaluation by a sane or forensic nurse. So let's talk about each of these real quick. So in Reed's scenario, this kiddo has disclosed to multiple adults, including DCS and his mom, and they're all discounting him. So the child may benefit from this matter also being reported to law enforcement if it has not already been done so. And this matter may be escalated to the DCS supervisor to arrange a forensic interview and ensure the child's safety, given his lack of support at home and the fact that the other child lives in the home. So any child who discloses sexual abuse has the right to a medical forensic exam. In Georgia's scenario, despite her being assaulted by her husband, and falling outside of the time frame for some activities for evidence collection, she also might still benefit from the medical forensic exam or other services. So she's the one that has visible injuries and pain and tenderness. So she might even need like radiographs to evaluate the extent of pain and tenderness to that left shoulder. In Ellie's scenario, she's the 2-year-old kiddo that is still diapered. Mom took her to urgent care. Urgent care said, she's fine. And mom just doesn't understand the information. She's not comfortable with this. So that child can be referred for a second opinion, which can allow the sane or forensic nurse the opportunity to provide an explanation related to that child's signs and symptoms, including, again, going back to differentials, is there a possible medical reason that we see blood in the diaper that perhaps has nothing to do with sexual abuse? That does happen. Labial adhesions are common in kiddos because there's very little estrogen. And so things can kind of just get adhesed and stick together. And then when they rupture, it will cause spontaneous blood in the diaper. And so it sounds like the healthcare provider just did not explain this well. And so mom has concerns. So having someone else kind of sit down with her and explain, child sexual abuse generally doesn't leave marks. These are the reasons why we believe this could be a labial adhesion. Here's what we know about labial adhesions. They are not the result of child sexual abuse, those kinds of things to help mom and put mom's mind at ease. Or if there's more information that we gain, maybe this is something that we need to report to get more information about. And then finally, in Jeremy's scenario, he is unable to recall details of the assault. He refuses to report to campus police, so he may also benefit from the examination and evidence collection, as well as evaluations of his injuries and treatment and prophylactic treatment for STIs. We can collect a kit on him, and that way, if he changes his mind about making a report to law enforcement, he has up to 1 year to make that report, and the evidence kit might be useful should he decide to report in the future. Let's see where we ended up here. Third place is Sophia. Second place is Mallory. First place is Blaze. All right, so hopefully y'all appreciate the game. I was hoping that it would break up the monotony of lecturing. So what other questions or concerns? I love that Mallory wrote, Ellie's mom reminds me of parents who have a gut feeling about someone close to them, but doesn't want to accuse them yet. Yeah. Yeah. Right. Yeah, it's true. No. All right. Well, thank you guys so much for your time and interaction today. And I appreciate being a part of this. And thanks to ICASA for having me back.